Good afternoon, everybody. Thank you for joining us on this lovely sunny day. Welcome to the latest in the series of BASRAT webinars, today covering osteoarthritis with Jack March. Before we do get underway, I'm just going to do a little bit of housekeeping, just so we've got all bases covered. If you do want to introduce yourself, you can do so in the chat box. Let us know who you are, where you're tuning in from, what your professional background is. It's great to see the diversity that we have attending these sessions. We'll be sending out certificates to all of you joining us live today. You'll get those tomorrow, and we'll also make the recording available for you so you can check back in on any slides and content. The presentation is going to be around 30 to 40 minutes loosely, and we'll follow that up with a Q&A. We'll fit in as many questions as we can, but we will try and stick to the hour. Thankfully, our speaker today, Jack, is very active on social media, and I'm sure he'd be happy to take any follow-up questions there as well. For the questions, if you could please post those in the Q&A box rather than in the chat, that would be much appreciated. The Q&A box is the one that looks like that, circled at the bottom there. Before you do post a question, just have a read of what's already there. Somebody might have already asked what you were thinking. If so, just upvote it and you'll bump that question to the top of the list, which gives it more chance of being answered. A little bit about BASRAT. We're the professional association and regulator for sport rehabilitators in the UK. We've been running these CPD webinars regularly now since March 2020, when COVID took hold. If you do want to support our work, you can do so by becoming an associate member, and all the benefits are listed for you there. It's £5 a month, and anybody who's interested can contact me afterwards via email or check out the information on our website. Our guest speaker today is Jack March, otherwise known as the Rheumatology Physio. He's very kindly given up his time to come and speak to us about osteoarthritis. Jack is the Rheumatology Clinical Lead for Choose Health. Alongside his clinical work, he provides CPD seminars on recognising rheumatology and other CPD topics, including OA. He has a website, rheumatology.physio, where he hosts all of his CPD content, books, ebooks, and courses. He's the operations director for the Physio Matters podcast, which I'm sure loads of you listen to. And he's previously worked across various advanced roles in rheumatology, orthopedics, as well as advanced physio in general MSK for Nuffield Health. I'll bring Jack in. Jack, if you want to come and say hello, and then we'll get things underway.
Hi.
Let's not leave the people waiting. Let's get those slides up. Let's max out our hour as best we can.
Let's crack on. Yeah, no worries. Thank you for my introduction. You've saved me time. I won't have to do so much of that now. Here we go. Right, let's present this. Yeah, thanks, Ollie. Let's get cracking. So we're going to talk about osteoarthritis and how the development of it is more complex than wear and tear. And we'll talk in some detail about that, and hopefully we'll get through that in about 20 or 30 minutes. This is all relatively new content. I've not really presented it before. I have spoken about it and answered questions about it and tried to write some things about it. So you're all a little bit of guinea pigs for me for this presentation. Obviously, normally I'm talking more around things like rheumatoid arthritis and axial spondyloarthritis, but we'll do our best. Osteoarthritis has been a bit of a passion project for me over the last 6 months as I've tried to understand it a lot better. So Ollie very kindly introduced me. So there I am waving like an idiot. I had a bit of less of a fringe in that picture, but spend most of my time working for Physio Matters, the podcast, and doing the therapy live conferences and creating resources for my website, rheumatology.physio. Where you can find all sorts of things. I try and do things in as many media formats as I can to suit everybody's different learning styles. So there's videos, text, audio, ebooks, downloadable, printable books, those kind of things. Here are some of those. I won't spend too much long on this. You can go and have a look around if you wish. Ollie, I'm going to put words in your mouth now, but I think Ollie's going to send an email out with a discount code for everybody who's attending, which will give you 10% off for the whole shop. Excellent. Yeah, that'll come by email.
You'll all get it in an email. It'll be Same time tomorrow. It goes out automatically 24 hours after the event. So this whole shop, including your OA book. Yeah.
Including the OA book, which we'll look at the end, yeah. So let's talk about osteoarthritis, because that's what we're here for. So here is the NICE guidance, and apologies to anybody who is not in the UK and not governed by, but uses NICE guidance relatively often. But it is similar around the world as well. So the NICE guidance for diagnosing osteoarthritis is to do it clinically without investigations. If the patient is over 45, has activity-related joint pain, and has none or joint-related stiffness that lasts less than 30 minutes. So it's no joint-related stiffness, or that joint-related stiffness is under 30 minutes. So that means you do not need an X-ray to diagnose osteoarthritis. You don't need an MRI, you don't need an ultrasound, don't need blood tests. You just need your brain and your clinical reasoning skills. So a couple of things I want to point out here that would apply to a lot of your patients' presentations, regardless of what they were attending with. So there is obviously a clinical reasoning process that occurs before you get to this point, before you diagnose them. So you are going to obviously rule out other clinically important conditions. So if a patient attends with knee pain and they had a flexing knee injury with rotation, then you might think that they've got a traumatic injury over osteoarthritis. But if there isn't anything else overtly causing the symptoms, and you think that their patient has osteoarthritis and they satisfy these criteria, then you do not need to investigate them. So they don't need to go to consultants or have, as I said, any imaging or bloods or anything like that. So you will still image these patients in a lot of situations, and usually that would be for ruling other causes out. Other causes of the patient's symptoms. So you might MRI for obviously a different reason. And the other option would be if the patient's symptoms rapidly progress. So again, that would be, let's say you've got a patient and they see you and you think, oh, that seems like it might be knee osteoarthritis. Go and do this physiotherapy or whatever it is or sports therapy or whatever input you decide that there is a good idea. Then their symptoms deteriorate quite rapidly. So over a few weeks or a few months, their symptoms deteriorate. Then you're going to get some imaging in order to make sure it isn't something else that's causing the symptoms, but also to see whether it is osteoarthritis that's diagnosing quite rapidly, because that does occur. But it is relatively rare. So diagnosing osteoarthritis is relatively simple. What we need to remember is there is a distinction between symptomatic osteoarthritis and radiological osteoarthritis. So in my opinion, we need to move away from saying, let's say you've got an X-ray and it says shows signs of osteoarthritis. We should move away from that osteoarthritis as we see here as a clinical diagnosis, not a radiological diagnosis. So it should show signs of joint thinning or sclerosis, bone sclerosis, or osteophytes, something like that. That's what you're seeing on X-ray. The symptoms are the osteoarthritis. So if they've got pain and stiffness on activity, then that's what the osteoarthritis is, and you're seeing joint changes on X-ray, which may or may not be related to that. So again, just to say, some patients will have radiological changes and no symptoms. Some patients will have symptoms and no radiological changes. That doesn't change the diagnostics of osteoarthritis, if that makes sense. So it is going to be a large proportion of patients. Osteoarthritis is very common. It's one of the most common musculoskeletal issues that we have. And we're moving more toward, a bit out of the scope of today's webinar, given the time frame that we've got, but we're moving from considering osteoarthritis as being a disease of cartilage, and it's moving towards a disease of the whole joint, and actually probably more of a disease of the whole person, which we'll see as we go through talking about pathophysiology. So it isn't just a case, as we said at the beginning, of it being wear and tear. So this is what I want to go on to start with, and this picture here is just really to demonstrate the old beliefs around how osteoarthritis would develop. So likening it the cartilage, let's say, very much to a car tire. So the more that you use the car tire, the more that the tread will run down, the thinner it will become, and in essence, the less functional it will become. So as people used their joints more, like let's say they were running or they played sports, etc., the more you use your joint, or the older you become, so the more time you've been using your joint, the more it wears down, and osteoarthritis being an inevitability. We don't believe that that is the case now. That's not something that we certainly shouldn't be telling patients. There is evidence to say if you use descriptors like wear and tear or bone on bone, or liken the body to something like a car tire or a machine, then that actually adversely affects outcomes for patients all on its own. So regardless of what other factors are affecting them, the fact that we're describing their body like that means that they are less likely to seek active treatments. They're more likely to end up on surgical waiting lists, more likely to have poor outcomes whilst they're waiting for those joint replacements. So it's certainly something that we need to forget and leave alone, or at least if someone comes in with that belief, we need to start dispelling it. And this is what we're going to spend the majority of this webinar talking about. So we need to reframe the way that we describe osteoarthritis and the way that we understand osteoarthritis. And I apologize for some double negatives that are going to occur here within the next few slides. But what we need to think about of the joint is, rather than this wearing away of the cartilage, we need to ignore that. That doesn't happen. It's not use related. But what we need to think about is that there is a natural turnover of cartilage, and cartilage is a relatively inert structure. So there's not very much. There's collagen within the cartilage structure, and there are chondrocytes which stimulate production and repair of collagen. So when you have healthy collagen, what happens is you've got a lovely smooth joint surface, and it's nice and thick, and it's very resistant to pressure as the joint takes load. So if you imagine the joint is compressing down, then it's resistant and thick, and so there's lots of cartilage to protect the end of the bones from taking load. That also allows nice smooth sliding of the joint. So I didn't tell you, but I'm pretending my fists are a knee here, so you can imagine the sliding motion of the knee as it bends and flexes under load is good. So when we start to talk about osteoarthritis, and again, remember that there's a distinction here between the radiological osteoarthritis and the symptoms of osteoarthritis. So if we talk about joint changes to begin with, then what we start to see in an osteoarthritic joint is that you get a suppression of the restoration of the cartilage. So that essentially the chondrocytes become less effective or less active. So over time, rather than it being an active degradation of cartilage, it's more that there is less restoration. So the amount of turnover of that cartilage is lower than the amount that's required. So there's a net negative turnover. So if you imagine this is the amount of cartilage you need for your joint to be 100% perfect, if you have a net neutral amount of turnover, then it stays the same. So it's turning over like this to the same level. If you have a net negative, then what happens is you're dropping down each time you restore a little bit, a little bit, a little bit, a little bit. And this is where the problems come in. So rather than, like we say, this rubbing away and this negative like sandpaper, it's this lack of ideal restoration that comes back. So this answers a lot of questions around the process of osteoarthritis and why some things might affect osteoarthritis more than others, and why joint changes will occur, multiple joint changes in multiple joints, for example, but also locations like the first CMC joint, the thumb, at the base of the thumb. So there's a really fun paper that's written, which is called Obese People Don't Walk on Their Hands. and showing that obesity was related to osteoarthritis of the base of the thumb, which clearly has no relationship to how heavy you are, then it changed a lot of the dynamics of how we might think about osteoarthritis. So something else, not load. Load is not affecting the likelihood or this restoration within the thumb. It's more to do with your systemic factors, of which obesity is one, which we'll talk about. So reframing this idea where this suppression of restoration, and if we can improve the level so that we're getting this, again, net neutral turnover of cartilage, then that can maintain the joint structures. At the moment, we have no way of getting what I would call a net positive turnover. So at the moment, we aren't able to increase the loss or increase the amount, which is a bit of a problem. There is some emerging evidence that entirely offloading the joint may allow some restoration or some increase in the amount of cartilage, but really what we're doing is we're going to try and maintain the quality and the thickness of the cartilage that we've got. But reframing the way you think about osteoarthritis in that way is the first step to understanding it better and then explaining it to patients better, and they will therefore or it has been shown that they'll engage in active treatments much more readily. So on the left-hand side of the screen here, what we've got is a list of various things that will and again, here's where we get into the double negatives. It will increase the suppression of the turnover. So the suppression is more, so you get more of a net negative, or the net negative is greater. So we know that genetics plays a role. So if your natural ability to turn over cartilage is lower, this again sits on a bell curve. Some people have a brilliant ability to turn over cartilage. Other people have quite a poor ability to turn over cartilage. Then your genetics will play a role. The effectiveness of your chondrocytes will be less effective than others. So you will see osteoarthritis run in families, and quite often, I'm sure many of you either have a history of osteoarthritis in your family and have osteoarthritis yourself, or you know of patients where their whole family, the parents have osteoarthritis and their children go on to get it as well. Obesity will affect in a negative how well you restore your cartilage. This is again talking radiologically, so we're talking joint structure now at the minute, but the obesity is actively going to increase actively decrease the restoration of that cartilage. So especially abdominal fat releases adipokines into the system, which are inflammatory upregulators, and inflammation is something that will cause poorer cartilage turnover. So that goes hand in hand again with injury. So if you think about joint injuries, you get a big boost of inflammation at the area. The classic one is an ACL injury, where you get a very internal high level of inflammation from that ruptured ACL or that torn ACL. And what happens is that inflammation affects the chondrocytes, and they are unable to have turnover as effectively. The same thing happens with joint surgeries. So this inflammation suppresses that function of the chondrocytes, and they are unable to get that net neutral. To a lesser degree, but still in the same sort of bracket, we have these, what I've just termed other poor health choices. That would be a poor diet, alcohol, smoking, and lack of activity. And inactivity has a couple of different factors in the way that it will help to develop this osteoarthritis. One of which is if you're inactive, you're more likely to be overweight. So the calories out versus calories in. But also with inactivity, what you're not getting is loading going through the cartilage. And it turns out the cartilage is much like every other structure in our body. You need to use it, or you do indeed lose it. So what we're looking at with inactivity is you get a lack of perpendicular force that we talked about into the cartilage. And it turns out that this is actually what stimulates those chondrocytes to be more active. So if you're not getting that load-bearing force into the cartilage, then you are going to have less active chondrocytes, and they're going to turn over your cartilage less effectively. And then finally, we would associate age very strongly with osteoarthritis. We know that the metabolic system slows down as you get older. People are more likely to be inactive as they get older. They're more likely to have more injuries and joint surgeries because they've spent more time on this planet. There's more likelihood of them having these things occur to their joints. So the age factor does come in, and obviously we see this escalation as people get older of osteoarthritis. So those things contribute to this degradation of the joint, or this lack of restoration. So the opposite of that, and this is, so those things on the left-hand side are things we want to try and avoid. The opposite of that are relatively obvious. So we talked about genetics. If you're on the upper end of having really good ability for your chondrocytes to turn cartilage over, then you're obviously lucky, but you can't really do very much about that. Good health choices, again, the opposite of what we talked about: not smoking, not taking a poor diet, not drinking too much alcohol. That means that systemic inflammation will be lower and it won't affect those chondrocytes so significantly. We need to apply loading. We don't have any evidence yet as to the type of loading that's effective, or more effective, I should say. Any loading appears to be effective. My bias would be towards heavier loading, but in all honesty, it can be anything. Even things like yoga and Tai Chi have been shown to be effective with regards to osteoarthritis. So what that will do is it'll improve that chondrocyte effectiveness, because what you're doing is you're creating that perpendicular force that we mentioned a minute ago. And weight loss is important, again, to get rid of that extra abdominal fat, or those adipokine releasing tissues, so that there is less systemic inflammation into the system. So offsetting those two things is a really good way of improving the way the cartilage turns over. And what we want, of course, is, as we said, we want to get to a net neutral. So it's turning over and maintaining that cartilage quality. So then we need to talk more about symptomology. So as we talked about, we've discussed what happens within the joint, but that is not guaranteed to cause symptoms. So what is it that then we go on to see, and why do some people get painful joints? Why is it even that you x-ray someone's knees and the left one looks terrible, the right one looks okay, and yet the right one is the painful knee? And there are a lot of complexities within that. So the symptoms that you're likely to see with osteoarthritis: you might get pain, you might get swelling, redness, heat, you might get some stiffness, and you might get some grinding. And those all come from the inflammation within the joint. So that's the swelling, the redness, the heat. It can cause some pain as well. The stiffness from the swelling, but also stiffness can occur a lot from the fluidity of the joint fluid. We know that if you've got a little bit of mild synovitis around the joint and your joint fluid is not created as slidey, I suppose, as it could be, then you will get some stiffness as well. The pain is very variable on a lot of different factors, but also this crepitus as well. We talked about where we get the net negative of turnover. It doesn't necessarily happen evenly across the cartilage. So you'll get crevices and cracks where some of it is thicker and some of it is thinner. And quite a lot of time, if you see those patients who have maintained joint space on x-ray, then what they've actually got is little crevices within their cartilage. So the thickness is still the same, but with dents within it, so that then it can grind, and that might be where that sort of earlier radiological or joint structure osteoarthritis is occurring. But why is it that you actually get pain? And that's an incredibly complicated question, and anybody that's been on social media and discussed pain within the last decade or so will know that it's far more complex than I understand, certainly. But trying to narrow it down a little bit to osteoarthritis specifically, then the best option we currently have is the biopsychosocial model. And as I've tried to indicate here, that has the human person in the middle of it. These will all be individual. So in some patients, you might have a giant bio effect that's causing lots of input to the system, which is why they're getting pain. So you imagine those really advanced joint changes. So osteophytes and very degraded cartilage thickness, for example. But you might have a very small bio circle as well, where actually there is very little biological change as yet, and other things are impacting. So it will be an individual set of circumstances that occur to eventually cause this experience of pain. So within the bio portion, we're talking about the amount of inflammation, comorbidities that might increase pain. So things like anxiety and depression, we know, are more likely to you're more likely to have increased symptoms with almost every condition there is. And also, as we talked about, structure. So if it is very degraded, or there are osteophytes that are impacting on the joint, then that can make a lot of difference. Within the psycho portion, the understanding, we talked at the beginning about those patients sitting on waiting lists who believe their osteoarthritis is due to the wearing out of their joints. They're much less likely to have tried active treatments. They're much less likely to be active because, of course, if they think their joint is wearing out, being more active is going to wear it out faster. But also, they're more likely to think that only a joint replacement or surgery is going to help their symptoms, which is not the case. So their understanding is very important. Their fear, as we talked about, if they're scared that their joints are going to wear out, that's going to be problematic. And entwined with all of that is to do with their beliefs, and even down to what they believe is happening at a joint level. If they think it's wearing out, that's going to be problematic. The social portion of this as well, what type of work they do, you do see an increased amount of symptoms in manual workers, but you don't see an increased amount of radiological change. So if you imagine you've got to be on your hands and knees all day, say you're doing plumbing or building or something, and you're having to lean on these painful joints, that's going to be far more entwined with what you're doing than if you're sat at a desk and you don't need your knees or your feet or whatever for the majority of your job and your ability to earn money. Function specifically as well, if people are not being able to go out and enjoy what they want to do, or even down to if they've got a dog and they can't walk the dog as far and they've got guilt with regards to that, or they can't look after their children as they might want to, all of these things can become problematic and feed into this whole issue. And their support system as well. So from the support system, there's sort of two main components. It's, do they have a social support system which allows them to continue? So are there people that can help, or are there people that can reassure them, or are those people actually getting at them and being negative and bringing them down? And also a health support system that appropriately helps them. So it's not dismissive, it is helping them to understand, and it is providing them with things that they need. So when you combine all of those things, and every single patient will come in with biological influences, psychological influences, sociological influences, and some of those will be bigger and larger depending on the individual, all feeding in. And this is why we then get issues with why do some people get lots more pain but the same structure? Why do people get different pain in different joints? Again, if we go back to our builder type patient, if they've got to climb ladders and they don't feel safe, then their knees might be a real problem, but actually their thumbs radiologically might be appalling, but actually they don't need their thumbs so significantly to feel safe, so they don't get so much symptoms, because then this is where the psychological aspect comes in. They don't have so much fear about falling off a ladder because their thumb hurts. So it all feeds into itself, and it's what is most problematic to the patient. So remembering that those radiological changes, if someone comes in with an X-ray which shows radiological features of osteoarthritis, it's not a guarantee of symptoms. It's about reassuring them that actually some of those changes we will see in asymptomatic individuals as well. So hopefully, what am I doing for time? Let's go. Not too bad. Don't think I'm doing too badly. So got more information on this, go into a lot more depth, and obviously we'll talk about some questions in a minute as well. Hopefully Ollie's got a good list of them for us. But I have written, it's about, I think it's about 8,000 words on osteoarthritis, and we go into more depth on how osteoarthritis develops, how I've changed the way I think about it and explain it to patients, and how treatments that we might apply can affect the system in a positive and a negative way. That is available on the shop, and hopefully this has whet your appetite a little bit for that, and you'll go and have a look at it. There is an ebook version and a printable version. The ebook version is a little bit cheaper because I obviously don't have to print it and send it to you. So it's can't remember how much it is. About £5, I think, but with your 10% off, that'll save you loads of money. So you'll be good. Yeah, so
the Q&A's on fire already.
The Q&A's on fire, excellent. So yeah,
we've got some good questions coming in.
Excellent.
High quality questions, which
high
I like.
quality.
I'm going to be a little bit self-indulgent on the obesity point, if I may, because I can't actually post a question. A quirk of Zoom. So you picked up on obesity and the suppression of that remodeling being evident radiographically. What value is there in the input of nutrition and dietetics with the treatment of OA and sort of, the whole anti-inflammatory diet approach and weight loss approach?
Okay, so I'll start with the anti-inflammatory diet. As far as I've been able to ascertain, there aren't any diets that specifically help inflammation. So you see, if you Google it, there's loads that'll be like, this diet will reduce your inflammation, or it's usually garlic, or there's one weird one that's like cider vinegar and other things, but they don't actually reduce inflammation as far as I've managed to work out. We're much more looking at diet from a point of view of general health, but also then weight loss as appropriate. So reducing the amount of calories, for example.
In adiposity specifically.
Yeah, to reduce the adiposity. There are also other effects that obesity has on the system. So we'll all be well aware that cardiovascular disease risk increases with obesity, and diets can help with that reduction as well, to reduce that. And there is, I talked right at the beginning, which we didn't have time to go into more detail, but we talked about how osteoarthritis is a disease of the whole person, and there are links with cardiovascular disease and osteoarthritis. So if you've got osteoarthritis, you're more likely to have cardiovascular disease. If you've got cardiovascular disease, you're more likely to have symptomatic osteoarthritis, and so on and so forth. So the whole thing is linked together. And again, it's a bit like the whole movement towards biopsychosocial approach to people, in that you don't have a joint in isolation. It's part of a human, and we have to understand that. I've forgotten what the second part of that question was.
No, you've got both.
Okay, great.
Yeah. I mean, I guess the other bit that I did scribble, and I couldn't decide whether you'd answered it or not, was the effect. So when you mentioned obesity, it was radiographically. From a symptoms perspective, what's the effect of adiposity and the increased inflammation, and do we see it also influencing symptoms?
Yes, so if you have a lot higher level of resting inflammation, so obesity would be one cause of that, you are more likely to have an increased level of symptoms. Not guaranteed, but more likely. Yeah. But we see that across the range of arthritis. So rheumatoid arthritis, spondyloarthritis, their symptoms are worse with obesity.
Yeah.
The other component of it is, once you have osteoarthritis, loading is then painful. So as we saw with the diagnostics, activity-related pain is related to osteoarthritis. So if you have more load from your body weight going through the joint, the weight-bearing joints, they will be more painful. So if you lose the body weight, some of the body weight, there is less force going through the joint, so it is therefore less sensitive. but it isn't, and I try to explain this in the book a little bit as well. It's not that the body weight specifically causes osteoarthritis, but once you've got it, it's then aggravating. So theoretically, someone who is 6'5" and weighs 14 stone, which probably isn't overweight, may have more symptomatic osteoarthritis than someone who's 5 foot tall and is 10 or 11 stone, which might actually be overweight because they've got more force going through their joint, purely because they're a bigger person. So it has all of these things.
There's a load aspect and a physiology aspect.
Correct. Yeah.
Cool. Okay. And while we're on it, because we have got time, reductions in weight and effect on symptomatology. I've seen sort of 10% touted for lower limb, so 10% reduction in weight, has a significant impact on improving symptomatology. Any thoughts?
Yeah, so there's really good data, and it's narrowing down really nicely. So 5% body weight. So we're only talking in overweight individuals, not in healthy weight individuals. So if you're overweight, I usually use a BMI of 25. It's a bit of a blunt measure, but anybody with a BMI over 25, if you can lose 5% body weight, that is sufficient to cause a clinically meaningful change in pain reduction. Ideally, you're aiming for around 11 to 16%. That's where you can get up to around 50% reduction in symptoms. So it's mad, like huge amounts of change. So 5% is the aim for a minimal clinical difference, but 11 to 16% is optimal. So actually, when you think about it, if someone weighs 100 kilos, which probably is quite overweight for most people, getting down to 90 kilos and losing 50% of your symptoms, that's not an unreasonable target. Obviously, it's complicated. Obesity is complicated. Yeah. It's not as sufficient to just stop eating cakes, but it's a real improvement. So those people that we talked about sitting on surgical waiting lists, not doing active treatments, and if you said to them, oh, you can have a treatment that will take 50% of your symptoms away, almost all of them are going to do that. But the fact that losing weight is difficult is more of a challenge, which is why we need these appropriate narratives so that they're not put off. Yeah,
100%. Right. Enough self-indulgence with my into what everybody else wants to know.
It was only 6 minutes of self-indulgence. That's quite good.
Yeah, it was. That's quite good. So, top question from O. Walmsley. I haven't got your full first name. Sorry, O. How do you explain to patients what's causing their crepitus? And an add-on from Sheena. How do you explain the pathophysiology? So this idea of restoration and suppression to patients.
Yeah. So with crepitus, I say that it is either caused by the sort of the lack of fluidity of the synovial fluid. So almost like that the fluid that's in there to lubricate the cartilage is not as slidey as it should be, so it gets a little bit stuck. Or I use that description I said before, where the cartilage is still thick, but it's got grooves in it. So as the patella, for example, moves across the patellofemoral area, then as it runs over those grooves, it creates a noise. And a combination between those two things will make the noise. Crepitus isn't really related to the amount of symptoms that anybody's gets. I've had a few patients who have come and see me purely because of crepitus. They don't have any pain. There's not much you can really do about it. Unfortunately, there are trialing treatments that might, like I said, might restore the quality of the cartilage. But to be honest, at the moment, from my point of view, I think the negatives outweigh the potential benefits at the moment. Like, you've got to spend 6 to 12 weeks non-weight bearing in a fixed brace. So you couldn't drive, you're going to lose all your muscle bulk, you're going to have to rehab.
Fitness. Yeah.
So, you certainly couldn't work, well, you could work from home, but you can't drive anywhere. Huge functional problem. You're going to have to rehab afterwards for some potential restoration. Like, that's a huge input to try and get some restoration of cartilage. So we're not there yet. And the injectables certainly haven't worked. So unfortunately, we're stuck with, like I said, I get to we can maintain what you've got and improve to a degree what you've got, but we can't thicken it back up. And then there was a question then about how do I describe the pathophysiology. I literally describe it pretty much how I did before. So what I'll say is, you know, your skin has a natural turnover. You know that you create dust, and new skin comes underneath, and you get this turnover of skin. And I use this sort of motion. You get a turnover of skin, and you maintain the same level of skin, which is here. And the same thing happens with your cartilage. You create new collagen, and it goes around in a cycle like this. But when you get osteoarthritis, what happens is you don't reach the top, and then you don't reach the top, and you don't reach the top, and it just goes down and down. That's why you get this thinning. So it goes down and down and down.
I like that.
And then you could be as complicated as you like with the other stuff that I mentioned, depending on your patient.
Yeah, because that's going to feed into it, patient's understanding of what I'm actually talking about. Okay, a little bit of a flip. Georgina, we're talking loading in the upper limb. Does that need to be perpendicular?
Okay, so the perpendicular issue is currently problematic. So there is an idea that movements other than perpendicular would reduce the function of chondrocytes. So they need the perpendicular force to stimulate them, but anything like this, which might give us a reason why osteoarthritis is much more likely in people with hypermobility syndromes and ACL deficiencies and so on and so forth. However, that's easily picked holes in because of the knee. So the knee doesn't flex like this. It flexes as a slide. So you're immediately getting forces that aren't perpendicular, but everybody's knee does that. So at the moment, I have a biological theory that exercises which were isometric and perpendicular. So for the knee, literally getting a barbell as heavy as you can, loading it, but not actually squatting, would be better for cartilage. However, it's only going to be better for cartilage. It's not going to be better for muscle bulk, bone structure, and all that kind of thing. So at the moment, what I suggest to people is that they use strengthening exercises, range of motion, as they normally would, with appropriate loading, and they don't worry about the other types of forces, because we just don't know, or at least certainly I don't understand the biology well enough to know. Because you could get really into, you know, what happens when if you have any varus movement or valgus movement in a squat. Actually, is that detrimental? Would that be more detrimental than the perpendicular force you're getting? No idea. We're nowhere near that. Nowhere near that. Load them is going to be way better at the moment than not loading them.
And whatever loading they can tolerate, fit in, have access to, etc., all plays a part.
Yeah, correct. So, I think swimming. I'm umming and ahhing over swimming. So you would load them in a certain way. It's obviously good for cardiovascular fitness, but it's not loading the joints like you would in the gym with walking or etc. So I think swimming can be used, and it might be a gateway into doing more exercises, but really it's got to be load based.
Okay, Sophie, a lot of love for Sophie's question. At what point do you think degradation is too great and surgery or joint replacement is the best option? Is it indicated by not seeing much improvement after loading and improving health choices, etc.?
So it's going to be quite patient dependent. And you have to forgive me for not knowing the exact indications for surgery on total knee replacement or total hip replacement, etc. I tend to advise people that if it's really significantly affecting their sleep, or really significantly affecting their ability to work or undertake their function, it's restricting the distance they can walk, that kind of thing, then it's starting to become the time when we need to consider the joint replacements. It's got not to do with joint structure. So what's not to do with what we see on X-ray. We shouldn't replace joints because of that. Except for in rare conditions where, you know, you've got a huge bone deficiency or something. But it's like, okay, so it is affecting those things. But as we just talked about, you get a big improvement with weight loss. But if the patient isn't overweight, they're not going to get a benefit with weight loss. if they're already active, they've already done 6 months, 9 months, a year of active therapies, they already live a healthy lifestyle, they don't smoke, they don't drink, etc., and there isn't anywhere for them to go, at that point you're really heavily considering a joint replacement. But I've met very few patients that you can't spend at least a year trying to optimize their health outcomes, and prehab in these patients is really effective at getting better outcomes anyway. So, you know, we're probably lucky at the moment in some fashion that elective surgeries, certainly in the UK, are somewhere between 1 million years time, aren't they? And, you know,
POA are saying about 24 months.
Well, yeah, exactly. Yeah. So the dinosaurs will be back before people get knee replacements at the moment. So there is time to say, look, we've got all this time to potentially work on these things. And just because you're on a surgical waiting list doesn't mean you have to stop active treatments or can't undertake active treatments. But it is quite an individual decision to make. But people have to be aware that, you know, joint replacements are brilliant, but they're only brilliant in the people they're brilliant in. There are some people where they're rubbish and they don't work. And when I spent a lot of time in orthopedics, the patients that did badly didn't have severe symptoms before they went in. They need to be very bad symptoms before they go and have a knee replacement or a joint replacement. They need to have tried all the active stuff, really. But it is an individual decision. And I think if someone really wants to go and see an orthopedic surgeon, then they have every right to go.
It's also not a magic bullet, and it's not as simple as saying, oh, well, I'll just have a new knee then. You know, there's still a lot of work that needs to go in after that, well, before and after that's been done, in order to make that a successful, you know, procedure. So
exactly,
the effort is going to go into rehab either way, whether you have the new knee or not. So you may as well give it a crack before you expose yourself to the risk of having major surgery.
Correct. Yeah, and we need to remember that not every joint can be replaced. So ankle replacements are pretty poor. The surgery for hallux valgus is pretty horrendous. Elbows, you can replace an elbow, but they're crap. Shoulder replacements are better now, but they're still not brilliant. You can't replace a wrist or thumbs. So, you know, knees and hips are one conversation. The other areas of the body are another conversation, unfortunately. And quite often I've said to people, you know, look, I know your knee's bad, but your ankles are also bad. Having a knee replacement probably isn't going to affect your ankle. Let's do all these other bits, see what happens. And in the end, they do improve, and everything will improve. So that's good. And that's the really good thing about having this narrative about it being the whole body issue. If you're improving your whole body and that affects one joint, then it will affect the others.
Yeah, for sure. Okay, so we're getting into some of the supplements and drugs questions, which I knew we were going to get. So I'm going to try and lump some of them together because I think they're quite similar. So Rebecca and Jennifer, I'm lumping your questions together on this one. So is it beneficial to take collagen as a therapeutic supplement? And then what's the evidence on chondroitin supplements? So that's a supplementation question. And then our drugs element is again from Jennifer. Is there any evidence that immunosuppressant drugs may play a part in chondrocyte activity or function?
Okay, so the classic one would be glucosamine and chondroitin. Brilliant example of how marketing can make lots of money and not any difference. So I liken glucosamine and chondroitin to, if you had a crack in the wall of your house, you wouldn't try and fix it by throwing bricks at it. That wouldn't work. That's what you're doing. You're going, okay, my cartilage, my collagen has a problem. Some of the things that make up collagen are glucosamine and chondroitin and other things, and therefore if I have more of that, it will fix my cartilage, which is not the case at all. So there doesn't seem to be any clinical benefit. Having said that, some patients will take those supplements and go, I feel better. Fine, who am I to say that they don't? My only problem with that is if they have the resources to buy those supplements, and this goes for the other supplements as well, like turmeric and whatever people might take. So if they are relatively well off, it's not a lot of money to them, and they want to take those and they say they benefit, fine, there are no real negatives to them. If it's someone who is poorer, they don't have much money. You know, the last thing I think would be appropriate would be that someone takes glucosamine and chondroitin, and that's quite expensive, and therefore can't afford the gym. That's not good. That's poor. Or even worse, I did once speak to a patient who was skipping a meal every week so they could afford glucosamine. Like, no, absolutely not.
Yeah.
That immediately you've got to stop. And that's the same with all the other supplements. If the opportunity cost to them is nil, by all means go for it. They can have it. Immunosuppressant drugs don't really affect the turnover of the cartilage. Steroid injections directly into the joint have been shown to have negative outcomes on cartilage thickness, so they're not ideal. So really, the debate is out for steroid injections for osteoarthritis. There is a negative effect, but also they have the potential to cause a good positive effect. So using them for holiday periods is not a terrible idea. Using them before someone goes in for a joint replacement. We just talked about prehab. Imagine you could give someone 2 months of good relief and they're going to have their knee taken out anyway. That 2 months might be really good for them to get some strengthening work in. So that has its place. They haven't really shown any effect of things like drugs that treat rheumatoid arthritis and stuff, haven't really shown any effectiveness for osteoarthritis, unfortunately. They keep trying, but they keep failing.
Cool. Let's get into loading. My favorite topic. Jennifer, again, smashing the questions, Jennifer.
Carbo loading. That's my favorite question.
I'm going to also lump Steve Ingram's question in with this. Thank you, Steve. I'm going to put them together. So you mentioned loading is helpful, but can overloading in exercise, for example, high intensity training, actually cause problems? I guess the short answer is yes. Manage load appropriately. Steve also says, you mentioned your preferences for heavy loading. Can you expand on this and explain why you have this preference?
So can overloading cause a problem? Theoretically, maybe. So we do see that if you take runners, there's some really big studies in runners, and they showed that the inactive population get much more symptomatic osteoarthritis, around 14 or 15%, than the active population. So that would be most of us, would be the active population. There is a difference in hyper elite athletes. So I'm talking mostly patients who are active as a job, not the rest of us. So in elite marathon runners, elite triathletes, etc., there was a higher rate of osteoarthritis than there was in the active population. So the active population was about 6.5%, the inactive population was about 14.5%, and the marathon runners sort of about split the difference, about 12.5%. So there is an interesting dynamic there where I think they're probably doing enough exercise that they're increasing their systemic level of inflammation because of this repair process they have to do all of the time. It doesn't affect their joint structure, but it does affect their symptoms. So there is going to be a proportion of patients there, but most of us aren't going to get to that. We're not competitive enough. We aren't dedicated enough to do it for such a long period of time at such a high level. So really, unless you're working in elite sport, I wouldn't be worried about it. And how many people who do that as a job are going to go, no, I'm going to stop because I might get osteoarthritis at 50. They're not going to. So I tend to ignore it to a degree. But the high intensity stuff, it doesn't really make any difference. It's more about this extended period of time of loading or running or whatever it is. And then again, I've forgotten the second part of that question. Oh, a preference for higher load. My preference for higher load, my preference for higher load is it just gives you more stuff. So if you look at osteoporosis, for example, it's a bit more effective to do high load exercises. Obviously, if you do high load exercises, you're going to get strength changes more readily. It puts more of a stimulus into the nervous system. It can be a little bit more efficient as well because it takes less time. But that's just a preference of mine. Like I said, the studies show you can do any type of exercise and it helps to an equal degree. There is no research that shows one type of exercise is better than others.
Cool. Right. I'm trying to keep up with the questions because these questions are on fire. Have you, if we run over our hour, have you got like 10 extra minutes?
Yeah, just there's like 224 people, so I'll just start charging people £1, and then I'll stay as long as you like.
Yeah, If we put Jack's PayPal in the chat,
yeah, I'll stay all afternoon. Yeah. Oh, I do have to go at some point. I've got to go and have my second vaccination at some point. So I can't remember when that is, but I've got some time now.
Okay, cool. Buy his book, pay him that way.
Yeah.
So, good question from Ollie. I'm calling him Ollie because it's my name. O Walmsley again. Thank you, Mr. or Mrs. Walmsley. Does the reduction in estrogen after the menopause have an impact on turnover? So,
not as far as I'm aware. However, my recent learnings from people like Rhiannon Griffiths, for example, make me think that there's likely to be an increase in symptoms. So the change in the hormonal balance changes. I'm way oversimplifying this. Changes the sensitivity of the nervous system, making women more likely to experience pain, for example, than prior. But as far as I've seen, there is no relationship between the menopause and joint degradation.
A follow-on question from Alison Jackson then. She mentions abdominal fat specifically and the effects on OA. She treats a lot of menopausal ladies with increased abdominal fat. So can we just maybe retouch on why it's abdominal fat in particular?
Yeah, so for some reason, and I don't know why, but the abdominal fat is more active in releasing the adipokines, so the inflammatory upregulator. So once you are older, although even if I'm saying that when you're 50 or 60, you've still got potentially 20, 30, 40 years of life left for those adipokines to make a difference. But it's when you're younger and that low level of inflammation, if you're overweight in your 20s and 30s, that's what's making the big difference. So if women, then again, same sort of answer really, if a woman then puts abdominal fat on later in life, her adipokines will be released, the inflammation system will be upregulated, might make it in the short term more likely to generate osteoarthritis, but osteoarthritis symptoms. But it is a slow burn. Most people, 98% of people, their joints don't deteriorate over a period of months. It is over a period of years. So it will take its time to happen. But again, it's just something that needs to be kept down as possible, because it, like I say, the abdominal fat is what's related to cardiovascular disease. In women, it's related to breast cancer. So one of the biggest related factors to breast cancer is girth, stomach girth, which is the same outcome because of the inflammation.
Cool. Right, we've got. I'm trying to get through. Try to get through quite a few. So Glenn, thank you, Glenn, for your question. What about decreased concentration of proteaminoglycans? I think he means over time and the onset of OA. Anything on that one?
Yeah, so we're
getting deep into physiology.
Yeah, you're starting to stretch me, to be honest. From what I can work out, it's at the moment, it's the activity of the chondrocytes that have the biggest effect. So there will be other things that are affecting osteoarthritis, and don't ask me to say proteaminoglycans. But so those, a lack of that will have an effect. Joint structures and angles will have an effect. So there is some theoretical difference between what we would call focal load, which is probably where some of the joint injuries cause a problem, but also people with a big Q angle, for example, if they're overloading the medial part of the joint, then you might get differences in the way the cartilage is restored because they're overloading one area versus the other. And you can imagine that if you're offloading one side, it might get thicker and push your joint further and further. So these things have an effect, but as far as I can work out, they are either minimal to the chondrocyte function, or they're just playing a part in the effectiveness of the chondrocyte function. So it's like it's the chondrocyte function is the big thing, and then everything else is a small component into affecting that. And to be honest, I don't understand the biology enough to really go into any more detail than that. Yes, it seems to be an effect, but how much I don't know. Small, I think.
Cool. Good answer, and sorry for the horrible question. We've got just a few more. And I think I can link a couple of them together. So we'll go for that. So Georgina, thank you for your question. We've talked about shear forces and different types of forces and whether they're helpful or whether they're not. Are there any specific exercises that you favour for OA? So I know that it's going to be joint dependent. So let's go lower limb, hip, knee as a common presentation. What would be your go-to?
I'm not very imaginative, so squats, deadlifts are what I would go to. But to be honest, in all honesty, I'm guided by the patient. So as I said, the research says no exercises are better than other exercises. They just need to do exercises. So ignoring the fact if they've got a specific functional goal, then you might prescribe exercises to achieve that specific functional goal. Yeah. Outside of that, just purely doing it for the prescribing exercise, I tend to go, what exercise would you like to do? And someone will go, walking the dog, at which point I add load to that. So put a rucksack on, fill it with books or water or whatever it is. There is no evidence that we need to do squats, deadlifts. We don't need to flex the knee even. It doesn't seem to make any difference. Loading the knee of any kind is beneficial in the lower limb or in the knee. So yeah, it's just applying load and then we're probably into the realms of adherence and how much people are going to do.
You've actually perfectly answered VJ's question already. What do we do about adherence? And it's that thing of saying, okay, well, what exercise would you like to do? And then I'll find a way to make it appropriate.
Yeah, exactly.
And
trying to make things meaningful and to a degree fun, I think really helps. Making sure that people understand why they're doing them. I think again, it's unhelpful if you're going, if we strengthen the knee, it will stabilize, then therefore it'll be less painful. I don't think that's a helpful narrative. I like to use load. I say load. I say we'll load the knee and these are the outcomes. You might get stronger. Your cartilage might be improved. Your tolerance to movement will be improved. These are the things that are going to collectively reduce your pain. Because it's not a pain killing intervention. It's about improving the function and the tolerance of that joint. So yeah, and trying to explain that, and then hopefully they're then on board.
Yeah, cool. I'm gonna just a couple of slightly more random bombs for the last two questions because I can't really link them together, but we'll go there anyway because I'm sure people will be interested in the answers. So what are the effects of sleep with OA? So I know there's some broader stuff around sleep and inflammation, which I'm guessing might be a factor. But
I haven't seen anything causative, but sleep, again, lack of sleep might be said with depression and anxiety. It's broadly associated with increased pain levels or increased levels of symptoms. So that's what I would be probably concentrating on. If sleep does increase inflammation, it probably doesn't increase it anywhere near as much as things like obesity or a joint injury or a joint surgery. Those things are going to be much more likely. But again, it's another piece to add to the puzzle and another nice thing to speak to people about.
It's in the biopsychosocial realm rather than the biological, although it might have some.
And everybody knows if you sleep badly, you feel rubbish,
Yeah, and then less likely to eat well, less likely to exercise, and especially exercise effectively, etc., etc.
Yeah.
So, all part of the puzzle. And then I almost hate to drop this one on you last because it's about steroid injections and PRP.
Oh yeah.
So we may as well cover that because it's always a hot question up there with surgery. So thoughts on steroid injections, thoughts on PRP?
I'm much more comfortable talking about steroid injections. My understanding of PRP injections at the moment is that they may give some anti-inflammatory effectiveness, but I can't see that they'd give more of an anti-inflammatory effectiveness than a steroid injection would. There are some various trials that are occurring at the moment on PRP injections. So I'm going to defer that until they're done. It's a bit outside of my area of expertise, PRP. And I don't think there's enough evidence for me to say I would ever advise anybody to go and have a PRP injection. Steroids are, yeah, interesting. So almost certainly they will cause a degradation of the cartilage in the long term, but they also have the potential to be quite effective in the short term. So as long as patients understand that, then I don't think there's too much harm in having a steroid injection. I think they're best used, you know, let's say patient, it's their son's wedding in a month's time, and they're like, I'm desperate to be as healthy as I can be or as fit as I can be to do that wedding. I know there might be some risks. Please can I have a steroid injection 2 weeks before, and hopefully my knee will feel better for that. And I know the symptoms will probably come back up to somewhere between 6 and 12 weeks. The other option would be, as I said before, some sort of pre-surgery. So they have it a few months before so that they can do some prehab, and they're going to chop the knee out anyway. So if it messes up the cartilage a bit more, it doesn't really matter. The problem with steroid injections, like we say, there are not an insignificant risk of getting an infection, not an insignificant risk of causing some other problems. Rapid deterioration of osteoarthritis does occur on occasion, and you know, it's not a perfect intervention for sure. So I try to advise people away from them as much as possible, outside of a few specific options. But yeah, not great, but not completely useless either.
Yeah, awesome. Right, we're going to wrap it up. Because we have gone over time. Thank you very much, and thanks for getting through so many questions. I think we've done like 18 questions there.
No worries, it's good fun.
Which is mental. Archie says he was looking through your shop the other day. Which of your books or resources would you consider essential for a new grad, or should Christmas come early and buy them all?
All of them, yeah. I think probably do myself out a little bit here, but my favorite ones are, I did a rheumatology clinical reasoning book, which goes through loads of different case studies. That's really good. And I particularly like this osteoarthritis one that I've done recently. So I'd go for those two to start you off.
And do go and check them out, guys. Jack's been really generous with giving up his time today to do this webinar for us and taking all the questions. No doubt we'll get pelted with questions on social media afterwards as well. So if you could go and check out his shop, engage with him on social media, get the book as a fantastic follow-up resource to the presentation today as well, if you want to dive a bit deeper. Please do go and do that. Final bits of housekeeping from me. When we boot you out of the webinar, we'll end it. It's quite abrupt. Everyone just disappears. You will be directed to a feedback survey. We'd really appreciate you taking just a couple of minutes to fill that out for us, because it allows us to improve our future webinars and to get topics included that you guys want to see. Like I said earlier, we will send you a follow-up email that will have the links in there to the recording of this, so you can watch back all of it, including the presentation and the Q&A. There'll be a link to the certificate if you joined us live this evening, and we'll link you in for how to contact Jack and where to go for more information. Cool. Right, we'll let you get off for your second jab, Jack. I'm going to go and have a sit down and somewhere not as hot as my loft at the minute. and we'll catch you soon. When I do end it, it will boot us out. So I'll say,
okay, no worries.
I'll say bye-bye and thank you once again for doing this for us today.
Thanks everybody. Thanks for all the nice messages in the chat that I'm reading. Thank you.
Yeah, it's great feedback as always. Brilliant. Thank you very much, guys. We'll see you all on the next one.
Zoom wave.